So let's be official because Jenny and I tend to ramble. So I'm going to try to be a little bit official. I'm Shiva Gofrani. I have been an OBGYN for 22 years, which is hard for me to believe. I'm here in Connecticut and I'm in private practice. I have 3 partners who I love, who are my crazy brothers, I call them. And we do a pretty grueling obstetric gynecology practice where we're on call a lot. So I do all the OBs, C-sections, vaginal deliveries, gynecology, the whole thing. I have 3 babies myself. I have 2 dogs who I kind of like more than my babies often. I've also been through a lot of miscarriages, so I joke that I kind of understand it. And I actually had ovarian cancer 5 years ago, but I am fine. And I have lots of stories to tell. And 2 years ago now, Miss Jenny Hayes Edwards, who is here, approached me when I was giving a talk about fear. And she said, I would like to get pregnant and I would like you to be my doctor. And I would like us to create a business where we have a course and we teach women about all the things. And so that's what we did. We started Tribe Called V, which is our online platform that so far has a pregnancy program where we talk twice a month. We do live Zooms. We have an ebook. We have members from all over the country who join us. So you are welcome to look into it at tribecalledv.com. Follow us on Instagram. We each have our own Instagram pages as well. They'll include that in the email that they send you. And so then Jenny had her baby. So I'll let her tell you that part, but we are really having a lot of fun. Both of us working full-time separate jobs, both of us mothering and parenting, and then building this platform. And starting in January, we're going to have all kinds of gynecology content as well. So we're excited. So with that, I'm going to hand it over to Jenny Hayes Edwards, who is more recent birther than me. And then we're going to launch into what really can you expect during pregnancy, because there's a lot of things. Yeah.
Right. Well, thank you for that little introduction. And yes, anyone who follows Shiva on Instagram knows she's an amazing, amazing human first, doctor, mother, friend, all the things. And when I decided, so a little bit of history, I am now 46 years old, but when I was 35, I froze my eggs. I was actually one of the very first women in this country to freeze their eggs using the current technology, the current science. And at the time, I didn't know that actually at the time, that so few women had done it. But I was really glad I did it because I was super, super stressed and busy with my work. I owned 3 restaurants at the time. And so I decided to freeze my eggs. And then long story short, a lot of things happened in the 10 years since I froze my eggs, but I didn't meet my now husband till I was 42. And then we ended up, he has kids from a prior marriage. So, when you meet somebody, you can't just get pregnant. So a little more time passed, but ultimately we ended up thawing my eggs. We made embryos pre-COVID. Then COVID hit. We had to wait some time. And then we did the transfer June of last year. And 10 years today, actually, I found out I was pregnant. The positive pregnancy test was 10 years to the day from when I froze my eggs. And then little Kyle Grace was born this past February. February 10th. So she is actually going to be 10 months old tomorrow. And for me, having a baby at 45, I've watched, dozens and dozens of my best friends have babies. My sister have 3 babies. I was there for all of her births. It's just one of those things that you just don't understand it until you're in it. And I just felt like there was a huge opportunity to work with Shiva and really, we documented my whole pregnancy, and we want to really, open up the conversation, make it more comfortable, talk about the things that you don't necessarily want to talk about, but are happening or that you're worried about, and really get into it. So you can, have more information in order to reduce your anxiety and your fears. And that's our goal. So here we are. And that was my story, my brief little story.
I love it. Okay. So for anyone who's jumping on, do me a favor and just tell us where you're from and how far pregnant you are, if you're pregnant or if you're trying to conceive. And if you have questions, you can put them into the chat and we will try to get to them. So just to give you an overview, we're going to talk really about, I can't say all the things, but we want to address some of the questions that you sent, Hatch, which luckily overlapped with some of the things in my outline. So we're going to go through stuff. Jenny's going to jump in. You guys are going to ask us some questions. I want to talk first broad about mindset and then really specific about things that you can think about with your own hospital or birthing center that you can ask if you haven't already. So hello from Dallas. By the way, I was just in Dallas. That is an amazing city. It's so fun. Okay, so many of you had questions when you wrote to Hatch that really had to do with what Jenny and I talk about a lot, which has to do with anxiety and mindset and fear. And our whole premise with Tribe Called V is increase your knowledge to decrease your anxiety. So my first and foremost little discussion I have with all the patients in my practice is at some point I try to sprinkle in casually some mindset modeling that has to do with setting expectations, because I really, really enjoy manifesting. And Jenny, by the way, is a master manifester. I mean, she manifested during her labor in ways that I found miraculous. But I probably manifest differently than other people in that I want to very concretely believe what I want to believe as the end point without actually concretely believing that every single thing in that journey is going to turn out the way I think. Because if I think that way, I'm often disappointed and then I'm filled with anxiety and fear. So what I mean by that is I really want patients to go into labor and pregnancy and delivery thinking, in the end, I am going to be happy and healthy and my baby is going to be happy and healthy. I'd like to believe, for example, that it's going to be vaginal and I'm going to try, let's say, this would not be me, but let's say to do this without an epidural, and I'm going to try to stay at home as long as I can. But that will only work healthily and appropriately if you couple it with the understanding and the knowledge that if things don't go that way, that is okay too. Right, Jenny? Like the patients who we see and the people that we see in our program who do best are not the ones who had easy unmedicated vaginal deliveries. They are the ones who really went into this with an open mind, with some desires and some ideas and feelings and emotions, but very much found a partner and a practitioner and a doctor or a midwife that they loved and trusted and collaborated with, so that in the end, whatever direction it went in, whether it was an easy vaginal delivery, no epidural, hard vaginal delivery with an epidural, pushing for 3 hours and ending up in a C-section, they all ended up feeling okay and happy and healthy and collaborated with because they were open-minded to the process and they knew that it went the way it needed to go, as opposed to a very dogmatic, I need it to be this way, and if it's anything other than this way, then I will be disappointed. Those people in life tend to not do well, tend to not be happy, regardless of the outcome. I think we all know that. So my best advice to all of you is don't be that person. Don't be that person that says it has to be a vaginal delivery. It can't be a C-section. I have to do it this way. And anything other than that is going to leave me sad, bereft, anxious and disappointed, because it's like a parable for life, I always say. Our lives in general should go kind of the way we hope, but we all know they all take turns and twists. I didn't think I was going to be, 51, almost 52, with a history of ovarian cancer, 6 miscarriages and 3 babies. And yet here I am. And within all of that, there was beautiful things. Jenny didn't think she was going to be 46 before she had her first baby. And here she is with a beautiful, healthy baby. So, in the end, it's all worked out. But because we are open to the process, despite both ferociously believing in manifesting. So if I had one piece of advice to tell you, it wouldn't be anything about like epidural or perineal massage or any of the things that we're about to talk about. It would be help your mindset to try to be positive, try to manifest, but be open to the process. Find a doctor or a midwife that you trust, that you feel collaborated with. If you don't feel collaborated with, don't stay with them and nickel and dime them with questions, because that's not going to lead you to what you want. Find someone new, which is not easy, but that would be our advice, right?
Yeah.
So on the mindset stuff, Miss Jenny, do you have anything to add to that before we decide about the more concrete things?
Well, I think it's, especially if it's your first baby, I think it's really easy to have a plan, right? Because when you don't have other children running around and you might just be focused on this one experience, you have a plan and you have something that you imagine to happen. And that's okay. I think that we all want certain things in life always. I mean, we always have things that we want. But like Shiva says, to reiterate, what I did was I imagined all the scenarios. I had one that I wanted to have happen, but I got comfortable with the idea of all of them. So, when it comes, a vaginal birth versus a C-section, breastfeeding versus formula, all of the things that are ultimately going to be paths that your journey will take, I thought about them all. And I really got comfortable with them all, even though there was a path that I wanted to take. So that would be my one advice, is just think about all the different scenarios. Don't get scared by them, but just imagine them and don't be nervous about them. Just think them through and let them kind of seep in.
Right. I love that. And I think, I mean, Jenny, I say this all the time. I think it's really natural to be nervous. I really prefer people not to be scared because fear doesn't have a place here. Most of the time, you're going to be okay, no matter what. Even when there's emergencies, patients end up mostly okay. And that can help decrease your anxiety and your fear. I think that when it comes to what Jenny said about imagining all the scenarios, I think we all know that many people, the minute they find out you're pregnant, want to come out of the woodwork and tell you their horror stories. I do not know why. It is really frustrating, right? Like they come out and they're like, oh my God, you're pregnant. Let me tell you about all the bad things that happened in my labor, all the bad things that happened in my C-sections, all the bad things that happened. And it's terrible. They shouldn't do that. I don't know why the world is like that. Instead, I wish, and this is what we try to do in Tribe Called V, to kind of, like Jenny said, review all the possible scenarios, giving them all equal weight, because in the end, they all have very appropriately good outcomes. Because if you need, for example, one type of intervention, it's because you really need it. I'm sure your doctor's not doing it if you don't need it. And so I think that understanding that your labor could go in a lot of different directions, your delivery could go in a lot of different directions. And like Jenny said, focusing on maybe what you'd like to happen, knowing that things might change. I think that when people come in thinking they're manifesting positively, they actually often do the opposite. They often say things like, I don't want a C-section. I don't want an epidural. If you know about manifesting, and if you don't, I would strongly suggest learning about it. But if you know about manifesting, it is not about what you don't want. It's really focusing on what you want. But it's also about expressing gratitude and having a kind of sensibility around you that the things are going to work out in the way that you need and to your favor. And that really is a different mindset than kind of saying, I'm just going to focus on what I want and what I don't want. That's not really the best way to go about it. And I would say, again, not the best way to go about life. When it comes to birth plans, nobody actually put that question into Hatch, but I'm going to address it because birth plans are now a very popular thing. Tell us your birth plan. And what I say to my patients is, I'd actually rather you not have a plan. This is a matter of semantics, but I think when you have a plan, then the concern is that if we deviate from the plan, things are not going to go well. But the answer is we're never going to be able to go according to the plan because guess what? The baby's dictating to us what we're going to do. So instead, we'd like to rename it things like birth preference. So I think if you said, I like to have a birth preference list, I don't think there's anything wrong with it. But I think in reality, and this is one of the things I want to review, your doctor or your midwife and your birthing center or your hospital are actually probably going to have already complied with a lot of things that might be on your birth preference list, right? So for example, I'm going to go through the list of things I want you to think about asking your practice because they might already do this. And then you don't even need to worry about putting it in writing because while putting things in writing does help manifest, it also becomes very contractual. So if you kind of hand that document to your doctor or midwife, it almost seems like this is what I'm ordering. And the answer is, okay, we can't always comply with all the orders. So let's talk about preferences. So for example, besides setting your expectation, because you might very well say, I actually want a C-section. That's okay. I actually want an epidural. That's okay. I want to try vaginally and I don't want an epidural unless I end up needing it, in which case I will ask you for it. So I think it's good to know what are the practices of your actual hospital that you're delivering or your birthing center. Do they have 24-hour anesthesia available? Will you potentially have to wait for a long time? Do they offer IV narcotic medication before the epidural, which most places do? I don't think of any hospital that won't, but birthing centers might not because the implication at a birthing center might be that you're doing this unmedicated. If you're at a hospital, do they offer nitrous oxide, which many hospitals do not, ours does not, but increasingly some places are, where you actually get to titrate your own gas in order to kind of numb the pain just enough, but it's not as much, for example, as an epidural, where you're not feeling anything from the waist below. Make sure you ask them about things like birthing balls. Jenny had a birthing ball between her legs called a peanut ball. She was in a lot of different positions. Most hospitals nowadays have nurses who are so well trained, and they really took cues from midwives because in Western medicine, we do like to try to be a little bit integrative. And the midwives really have taught us that different positions can help the baby descend and get into the pelvis, and it can help your hips. So do they have their own peanut balls and birthing balls? Do you need to bring them? Many places have them. What are their practices with regard to you having an IV? Many places won't require you to have the IV drip going, but they'll want you to have the IV placed in your arm so that they can hydrate you when you need, and you're able to drink enough clear liquids on your own, for example. Will you be able to walk around with a monitor or unmonitored for a period of time? Will you be able to do, and many places will do this, nowadays the standard is that we do not cut episiotomies. And we're going to talk more about episiotomies in a few minutes, but we don't routinely cut episiotomies. We often do delayed cord clamping, where we leave the baby attached for at least 45 seconds, if not a minute, so that the baby gets more of the cord blood. We try to do skin to skin, and we do delayed bath for 24 hours. And these are all things that, again, we've taken from the more holistic midwifery literature, and it's really been found to have good outcomes. So those are all things that patients tend to come to me and say, well, I want this, this, this. And I always say, great, guess what? We already do that. So it's nice to know about it. And maybe you talk about that with your doctor before you even write the birth preference, because then to me, you've already felt like, great, I don't even need to ask these things because these are standard in our hospital, right? So Jenny, those are all things that you and I had talked about a lot, especially in our program. But those are things that, right? Is there anything else that you can think of that people tend to put on their preference list that I haven't thought of?
No, I think that's it. The only thing I might add just from a patient perspective is don't worry about, I got strangely obsessed with what I was going to be packing to bring to the hospital. And
that's the organizer in you though, right?
Yeah, I think I just wanted to ensure that I had like all the things that I'd want. And plus it was also height of COVID. So that it wasn't as easy for my husband to come and go if we forgot something, but I would say not to worry so much, because like I had like essential oils and a playlist. Like I didn't open any of it. Like I didn't end up using any of it. A super long phone charger was one thing that everyone said, because the plugs are often quite far away from the bed. So that was one thing. And you do not need to bring a lot of clothes. I don't know what I was thinking, as if I was going to change clothes every day when you're at the hospital. Like you don't. You just need an outfit to go home in. But I don't know why. That was like one of those random things that I was like obsessed with. And I was like, why was I so worried about that? So I just thought I'd throw that in there because that's not medical. But
and I agree. Clothing, I would say you really don't need that much of. I will say that long phone cord charger. Remember, I've told you this, that one of the most interesting, like simplistic things I've seen people bring that I thought was so fabulous that I wouldn't have thought of is an airplane pillow. Because when you're sometimes sitting up in bed, it's nice to have that pillow, especially postpartum. I will say, having coached and seen millions of women through labor, many women do like to have their essential oils, and many women do like to have their own playlist. So I do think like have those things. And to Jenny's point, like she had them just in case, and she didn't end up using them. But if she had used them, that would have been okay too.
Yeah.
I want us to like pepper in discussion of, I can't go through all of what could happen in labor, but I do want to discuss a couple of things that might happen in labor, because I think if you've heard them ahead of time, especially if you haven't done a birthing class, it will give you less anxiety if it happens. And these are common things. First of all, when it comes to inductions, quickly to tell you the background, that up until about 2 years ago, the rule of thumb was you do not induce women until they are 41 weeks, unless there is a medical indication, because the belief was through data that it might increase the risk of a C-section. So again, if there's a medical indication, like the patient was either older or had hypertension or diabetes or growth issues, those are some of the examples, we would induce at any point. But unless there was an issue, we would wait until 41 weeks. If someone was dilated a couple of centimeters, then they could be induced at 39 weeks. But again, that was typically second or third time moms. So up until 2 years ago, you would stay pregnant until 7 to 10 days past your due date, at which point we would talk about an induction. A huge trial came out 2 years ago that your doctor might talk to you about, called the ARRIVE trial. And that acronym stood for a long study where they looked at thousands of women, literally tens of thousands of women around the world, and found that if we induce everyone at 39 weeks, in fact, we'll have better outcomes, meaning more likelihood of vaginal delivery. So the polar opposite of what we were initially taught through studies, because babies would be potentially a little bit smaller. Babies would be a little bit easier to come out vaginally because their placentas would not misbehave during labor, and far lower likelihood of concerning issues towards the end that I hate to even mention, but things like stillbirths, which are already a very low risk. But that study showed a decrease in the already low risk of stillbirth, but made it even lower, because between 39 and 41 weeks, some of those placentas just get tired. That doesn't mean that many hospitals enforce induction at 39 weeks. Our hospital, for example, doesn't enforce it. Our practice doesn't enforce it, but we now have the latitude of offering it. And some patients want to be induced at 39. Some would like to wait till 41. So that's something your doctor might talk to you about, so just so you know the background. You might go into labor on your own. And if you've taken a class, you've heard the what ifs. And I usually say to patients, the beginning of your first labor can be really confusing. The obvious signs you call your doctor would be your water breaks, you're bleeding, or the baby's not moving. Any of those three things, you call your doctor, and then she'll help decide with you, should you go to the hospital or should you see her in the office? But the fourth time you call your doctor, which can be very confusing, is when you think you're in active labor. Luckily, I guess, Jenny didn't have to get to that point because we had to induce her. But that beginning of active labor can be really confusing because it might start like, God, I'm having tight, hard, just discomfort, or I'm having really bad cramps, both of which can be forms of Braxton Hicks. And they either go away when you hydrate or when you change positions. And that can happen anytime after 34, 35, 36 weeks. Or once you get closer to the end, those Braxton Hicks might start turning into painful, regular contractions. Many birthing classes will say, stay at home until those contractions reach a really regular tenor. And that would be when they're 5-1-1, we call it, every 5 minutes for at least an hour. And the reason is, you might be contracting every 6 to 8 minutes, every 8 to 10 minutes, or every 5 minutes for 30 minutes, for example. But none of those is probably really active labor yet. And that can last a really long time of those kind of in-between contractions where you're exhausted. But again, until they're every 5 minutes for at least an hour, it might not be active labor. I say to my patients all the time, if you're confused and worried, just call us. We'll help talk you through it. But in an ideal world, if patients could stay home until it's every 5 minutes for at least an hour, many more patients would walk into the hospital at about 2, 3, 4 centimeters, meaning well underway into labor. And that's assuming you're feeling the baby move, you're not bleeding, and your water hasn't broken. So talk to your doctor about what their parameters are, but what I just went through is pretty standard. So then you get to the hospital, they check you in. You might be in a rule out labor situation where your labor has progressed and it seems clearly obvious and your water has broken, or you might be 1 or 2 centimeters and they keep you for a couple hours and even potentially send you home, provided you're okay and the baby's okay. And that can be really exhausting and frustrating. And that's what we try to ideally avoid, but it's unavoidable. Many of our first-time patients end up in and out of the hospital 1 or 2 times before they're actually in labor. Again, provided they're safe, provided there's nothing wrong with their blood pressure. Once they determine you're really in labor, nowadays during the COVID, most hospitals will COVID test you. Many hospitals will ask you to keep your mask on regardless, but during the pushing stage, they often let you take off your mask, but you should talk to your doctor about what that standard is. And most hospitals will not test your partner, though some do. So you can also ask what they want from your birth partner. Most hospitals will not ask for any proof about your birth partner's status, but they'll still ask your birth partner to wear a mask. So once you're there and you've gotten your IV and then you're in labor, then you get to decide about things like, do I want an epidural or not? Do I want IV pain medicine like morphine? So Jenny, you end up getting morphine first. And I think it's a good opportunity for you to say a little bit about what happened because you were induced. Mm-hmm. It took a little while for us to really get you into labor and then you were in pain. So tell us about the morphine.
Well, what's interesting about, so the induction, obviously my blood pressure was had kind of gotten a little erratic. And so Shiva felt that it just made most sense with my age and stats and all that we induce a week before my due date. And, again, it was one of those things where I was like, oh, wow, I didn't really plan that, but it's okay. Cause I just imagined I'd be at home and I'd be like, ooh, and like feel my first labor pain. And, but that didn't happen. So we went typically, I don't know if this is all hospitals, but are inductions usually done at nighttime?
Totally depends, right? So remember, like some of our patients some of the people in our group will go early in the morning. So it depends. Every hospital is different. And frankly, every practice is different. And it also depends on the circumstances that you're getting induced and whether or not your cervix is dilated. So it could be late at night. It could be early in the morning. Depends.
So we went in late. We were on the late side. So they didn't start the induction process till about 10 p.m. And one thing that whenever I tell my story, I just strongly encourage people to voice what is happening. Because with me, I was so afraid of getting sick from the morphine and some of the drugs that I held off longer than I should have. And so what that means is they had given me some not morphine, whatever they would do before morphine. What would
we didn't give you morphine. We didn't give
No, but before morphine, because I didn't do morphine until like 4 a.m.
Demerol?
Yeah, I don't remember, but it was like just a basic, it wasn't much. I was having contractions, not like big ones, but I could feel them very often. And so what happened was from like 10 p.m. to 4 a.m., I was just sort of sitting there in pain, and it's dark. Okay. And the nurse does not want to come in every 2 seconds. So you're kind of by yourself and you're a little bit on your own if everything's going smoothly, that is. And I was so afraid of getting sick. I didn't voice that, but I just said, I don't want the morphine. And finally at 4 a.m. when she was like, you seem really uncomfortable, I said, well, I'm just really worried about getting nauseous and sick. And she's like, well, we give the morphine with an anti-nausea. And I was like, I really wish that I had said that like 6 hours ago. So I got that at like 4 a.m. And then from 4 a.m. to 8 a.m. I slept, and that was huge. So I just want to throw that out there, that I didn't get sick and I was able to sleep for those 4 hours. And that was really, really huge. So I recommend it.
I think it's a great point, because I think, listen, some nurses or doctors are obviously very talkative. So they would be like, why are you resisting from the very beginning? And then you would have learned that early. And also, here's the truth. Many doctors and nurses, like anything in life, do talk about a lot of things, but it's hard for you guys to remember and absorb everything. You won't remember and absorb everything. So to Jenny's point, talk to your nurses, talk to your doctors, ask them questions so that they know, because there's a lot of presupposed knowledge, but there's also, like, the nurses don't want to come in every 2 hours because they don't want to wake you up. They want to believe that you're sleeping and resting. Right. I know someone right here, Stephanie, has to, they give morphine. And yes, so different hospitals, different practices, but many hospitals will offer something initially if you don't want an epidural, or if you're not ready for an epidural, and it's often IV narcotics, meaning morphine or Demerol are the common ones. They are totally safe for you to take, but the IV medication does get through the placenta to the baby. So it can make the baby kind of seem sleepy on the monitor, meaning when you go in and you're in labor or induced, you'll have an IV, and then you'll have fetal monitors on, meaning you'll have a little round circular thing that sits on your abdomen that detects the baby's heartbeat, and you'll have another one to detect the contractions. And so they'll be monitoring the baby's heartbeat. And when patients get morphine, the patient gets sleepy and the baby can actually appear a little sleepy, but it's not dangerous. The benefit to the morphine is that it takes the edge off and you can fall asleep in between the contractions. The downside to the morphine, to Jenny's point, is it can make you feel nauseated, even with nausea medication, and it can make you feel a little dissociated. So some people don't like that feeling. And so some patients and doctors would advocate for getting an epidural earlier. And that's something that you and your doctor can decide. The good news is I tell patients all the time, like, they'll tell me at 36 weeks, like, do I need to tell you now that I want an epidural? And I'm like, you can tell me now, but you don't need to tell us that until you're there at the hospital, because it'll depend on a lot of things. How do you feel? When do you want it? You have some latitude. It's not as though, like, I order it right now and I want it this second and I get it immediately. You might have to wait a period of even up to an hour between your lab results being ready, because they'll want to make sure your blood count and your platelet count, which are two components of your blood, are okay before they give you one. And they need to make sure the anesthesiologist is ready and there. At our hospital, we have 24-hour anesthesia, but some hospitals don't have it 24 hours. They have to call someone from outside in. So it's good to kind of know when I'd like my epidural, how long is it maybe going to take? Those are things that I think it's a nice thing to ask your nurse or your doctor, because they make some assumptions that you might know those things. And of course you won't. Once Jenny got her epidural, she got to relax a little bit more.
Yeah, but that was a while later for sure.
And so by the way, do you want to just rules? Yeah.
Just Stephanie just asked, is that Pitocin? Just clarify that that's not.
Yep. Okay. So morphine is a pain medication. It is a narcotic. So that is strictly for pain. Pitocin, just so everyone knows, is the synthetic form of oxytocin. Oxytocin is our own endogenous hormone that puts us into labor and makes our uterus contract. So if you're in labor on your own, your body is releasing oxytocin. If you're not in labor, meaning you need to get induced, or you're in early labor and you get augmented, then your doctor will give you an IV drip with Pitocin, and that is what makes your uterus contract more regularly. There's a lot of confusion, and many people will say, I've heard Pitocin makes the labor worse than labor on its own. And the honest answer is that's really not true. Meaning you need a certain level of intense contractions to put you into labor, and your body's perception and your brain's perception of those contractions is going to be painful or not. Some people are lucky and they have very little pain despite being in labor, and others of us are in a lot of pain. And that's regardless of if it's oxytocin or Pitocin in the IV. Do you need morphine and an epidural, or can you go straight to the epidural? And the answer is it really depends on you. So no, you do not need morphine. In other words, many patients don't want morphine. They want to either wait it out till they get their epidural, or they just don't like the way they feel on morphine, or again, morphine or Demerol, the two common ones that are narcotics. And again, it depends a little bit on you and a little bit on your doctor's practice. I do not make patients wait. In other words, I'm a proponent of, if you are in too much pain, the pain release and the hormone release that happens during that pain, I believe might fight against labor. So if someone can wait it out until they're a couple centimeters dilated and they want to, I would let them. But if they're kind of stuck at 1 to 2 centimeters in that really early part of labor, that can take a long time. Sometimes the best thing they can do is get an epidural, then they relax, and then we see their cervix dilate and open faster sometimes. So again, you do not need morphine or Demerol. Those are the IV narcotics. You should talk to your doctor about whether or not you want them or she will offer them. And does she have any philosophy about the epidural as far as when to get it? Because there is no rule. How many hours does an epidural normally last is a great question. And the answer is it could last for a really long time. Like in Jenny's case, it only needed to last probably 12 hours, not even 12 hours, I think.
I got it around noon and the baby was born at 7.
Yeah, so 7 hours. In my case, I had 1 vaginal delivery. I had 2 C-sections that, by the way, were by choice because my vaginal delivery, unlike Jenny's, was more challenging and not something I wanted to repeat. I'm glad I had it for various reasons. It helped inform me a lot that there are beautiful deliveries that are vaginal and there are beautiful deliveries that are C-sections, and it all depends, not necessarily on them being easy. I can have challenging C-sections that are beautiful, easy deliveries that are not. It depends. But my epidural actually lasted about 24 hours. And so a lot of it has to do with your anatomy and how easy the epidural is to place, but many epidurals will last a long time. Sometimes you need redosing of your epidural, meaning something called a top off, where the anesthesiologist will come in and give you a little bit of extra medicine. But you can get your epidural early if your doctor feels that it's appropriate. And again, that's a little bit doctor dependent. They've tried to come up with studies as to whether or not it prolongs labor. The bottom line answer is it doesn't prolong labor appreciably. But many of us believe that if you can wait till you're in really active labor, that might be best. But again, that's all things being equal. I would never personally enforce suffering on someone just to get them to active labor, because sometimes I think that suffering is going to make it even worse and harder to get to active labor. So let's say you've gotten either morphine or an epidural. Then what's going to happen is the nurse is going to be in and out of the room, changing you into different positions. And that is partially to help your pelvis open so that the baby's head can descend, but it's partially because the baby might enjoy one side versus the other, meaning you might be lying, for example, on your right side or on your back, and then all of a sudden a bunch of people run in because the baby's heart rate, which is being monitored pretty much constantly if you're in a regular hospital and the nurse's station is watching the central monitoring, the heart rate might drop. And this is one of those things I'd really rather everyone know preemptively so they don't freak out when it happens. It is not unusual in almost every labor to have 1 or 2 episodes where you're lying there peacefully and all of a sudden, 2 to 5 people come running into your room, a nurse, maybe a resident doctor, maybe a doctor. They flip you into different positions. Sometimes they put oxygen on you. Sometimes they open up the IV fluid and they check your cervix. And that is because if the baby's heart rate drops, because throughout labor, it will sometimes have what we call accelerations where the heart rate goes up. It will sometimes have decelerations where the heart rate goes down. There are a certain amount of decelerations that we very much tolerate, but when the heart rate drops too much, then we want to change the positions in order to try to get the pressure of the baby off of the umbilical cord, because that is what can sometimes cause these heart rate decelerations. Most of the time, we're able to alleviate those decelerations by, again, changing your position, maybe giving you IV fluid, occasionally giving oxygen, which is not used as much as it used to be, but those situations can really help. Also, right after your epidural, you will not infrequently have a drop in the baby's heart rate. And that's because your blood pressure can drop from the epidural. That can sometimes make you feel a little bit nauseated. And that blood pressure drop of yours can sometimes show up in the baby's heart rate. These things aren't dangerous. They're very common. We see them a lot, and the vast majority of time they resolve and the baby's okay. But it's better for you to know that so that you don't feel freaked out at the time that it happens. I don't think that happened. I don't remember I do feel like you had some decelerations, but I don't remember there being 1 big drop.
2. I
remember when you got sick, but I don't remember the baby's heart rate dropping.
Oh no, it was just my heart rate.
Yeah.
Just mine.
And sometimes when you feel that sick again, your drop then proceeds to cause the baby's heart rate to drop. And it can be nerve-wracking for the patient, of course, to see that many people running in. So again, if it happens to you, please remember us saying it's very common. The vast majority of time it resolves and does not require an emergency C-section. So
Oh, sorry. I was just going to jump in really quickly, just that, because one other question, I'm not sure if I fully understood, but the reason I did do the morphine though, is because it was clear I was very far away from active labor. So for me in that moment, I was not ready to be numb from the waist down, because it would, then you're like, then you're in bed, like you can't, I mean, it's, so
Yeah.
for me, it was a decision that made sense in the moment to do the morphine, which I did, and then got me through to like 8 a.m. I woke back up, and then from 8 to noon, I was pretty much in labor. But to Shiva's point, for me personally, what I was wanting to do is I did want to feel active labor. I wanted to experience that. I did not want to, throw myself on the sword and like be some crazy person, but I did want to experience it. And I don't know if I read it or she said, if you can get to a certain point before the epidural, that's great. And I got to about 4 centimeters, and then I kind of got stuck at 4 centimeters. And then you just sort of know when you're like, okay, I am ready. Like I am ready. And then the anesthesiologist comes in. It takes like about 15 minutes for the whole thing to happen. And then probably another, 10 minutes maybe for things to kind of work. And then,
depending.
And then it was like,
then you feel better.
After that.
Well, and to Jenny's point, so Jenny wanted to feel labor. Jenny is in very good physical shape. She does a lot of physical activity. She does a lot of aerobic activity. Shiva, not in good shape, not a lot of physical activity, not a lot of aerobic activity. So when I was induced with my first and only vaginal delivery, I was like, I do not want to feel a lot. And at the time, my doctor said, I'm going to break your water at 1 centimeter. And because I love him and respected him, I said, I will let you break my water. And within an hour, I will get my epidural. And I got it at 1 centimeter. And I say to patients all the time, my way was not right. Jenny's way is not right. It depends. And just like she said, you'll know when you know, and every person is different. There is no shame. We all get a medal. We are here on earth. We all get a medal, whether or not we birth, whether or not we birth vaginally, C-section, breastfeed or not, everyone's getting a medal no matter what. And so really decide that you are not going to put into your mind rules, but these are generalizations where you'll see how you feel and you'll discuss it with your doctor. I'm going to address Stephanie's question in a second about massaging the belly for the placenta, because I want us to go back through what happens. So now let's say you've had your epidural or not. And now if you've had your epidural, because you can't move that much, the nurse will be flipping you around and she'll be putting potentially this peanut shaped big ball, it's like a big yoga ball, peanut shaped, in between your knees, in between your legs. There's all these new positions that nurses have learned that can really help open up your pelvis. They're funny names like flying cowgirl, fire hydrant. They sometimes have the bed sitting up, sometimes have your legs dangling over the bed. And again, these have really been shown to improve outcomes because we have more vaginal deliveries. And at certain points, the resident doctors, the nurses, or your own doctor will be in and out to check your cervix. Don't be surprised if you don't see your own doctor, sometimes the entire labor until the end, or just intermittently throughout. I joke with my patients that like, if you don't see me a lot, that's actually a sign that things are going really well until you start to push, in which case I want to be there when you're pushing on and off because I want to see how things are transpiring. And ideally, once you're in more active labor, which is when your cervix has reached anywhere from 3 or 4 centimeters to 6 centimeters, then you'll start ideally dilating at a more regular clip, but sometimes it takes a while. And to Jenny's point, she got a little bit stuck at 4 to 5 centimeters and it took a little bit longer than the norm, but we waited it out because she was okay, the baby was okay, and we increased the Pitocin, and we have a couple of other different tricks. And then she started to dilate more regularly. At the point that Jenny started pushing, and this is very common, the baby's heart rate was decelerating again, meaning dropping. And often that's because the umbilical cord can kind of be compressed by the baby's head. It can actually be wrapped around the baby's neck, which is incredibly common and sounds very alarming to patients, but 25 to 40% of babies have a cord wrapped around their neck and they're okay. So these things can manifest in heart rate drops, which during Jenny's pushing, I was a nervous wreck because she is my good friend and business partner. But what happened was very common. The heart rate would drop, it would come back up, it would recover. We made sure that the baby was okay, and she continued to push for 3 hours. So one of the things that I really want first-time moms to know is having a labor that, for example, is 24 to 36 hours is not uncommon. Having pushing that is anywhere from 1 to 3 hours is not uncommon. I often joke that if you can get a first-time labor under 24 hours and first-time baby out pushing with less than 3 hours, then that's amazing. That doesn't mean it's not exhausting. That doesn't mean at the end you don't feel like you just ran a marathon. That doesn't mean that you're not going to have swelling and some other things we're going to talk about with the perineum. But that all in all is actually a pretty good labor. Once you get past 3 hours of pushing, once you get past 24 hours of labor, that really veers on, it's a much harder thing to recover from, but you can still recover. And the truth is that along the way during labor, The baby's heart rate occasionally will drop in a way where your doctor says, I no longer feel like this is safe for us to try. Let's go ahead and do a C-section. Or your cervix has stopped dilating and we tried all our tricks to get it to dilate. And now we have to switch gears and do a C-section. Or you get to fully dilate, you push, and the baby still does not want to come out. Again, a reason for potentially a C-section. The most likely reason for you to get to fully dilated, push, and the baby doesn't come out also goes along with something that could happen during labor, which is back labor. So if you guys have all heard about back labor, you might have heard that it's really uncomfortable, but it basically means the baby's head can be down the way it should be, but not looking towards your spine, which is ideal, but instead looking what we call sunny side up, meaning the face is looking towards your front. So the back of the baby's head is kind of grinding on your sacrum, and that can lead to back labor, meaning your sacrum feels like it's something is sitting on it. And when that happens, it can just mean that the diameter of the head that's trying to come out is bigger than a typical diameter. And that can lead to longer labor, a little bit more tumultuous labor, and a little bit harder pushing, because now you're trying to push essentially a bigger baby out whose, anatomy and the shape of the head doesn't necessarily jive with the shape of your pelvis. And that's not the baby's fault. That's not because the baby is stubborn. I always joke that's because the shape of your uterus or your pelvis has allowed the baby to be in that position. And this is where the nurses changing positions using peanut balls has been shown to help a lot. But in the end, not every baby wants to come out vaginally. And again, I'll keep repeating it. That is okay. We don't want to force every baby to come out of a place that he or she might not want to come out. So once the pushing starts, that is where you're really exhausted, but that is where the nursing and the coaching can really help. Once you start pushing, your nurse or your doctor might be in and out using either mineral oil, some lubrication, examining you to see if the head is coming down so that they can really monitor and make sure everything's okay, but also thinning out your perineum. So I want us to talk a little bit back about what you can do at 35-ish weeks to start to help this process during labor. And then I want us to talk about episiotomies that Jenny knows about. And I want us to talk about pooping during labor. We love to talk about pooping during labor because we like to debunk the things that everyone else gets so embarrassed about. So I want us to touch upon, Jenny, you know what I'm going to say, the two things that you can start at 35 weeks, which is perineal massage and eating dates, literally the fruit, dried dates, to help thin your cervix out. This is where I will cover my and say, please talk to your doctor and make sure your doctor is comfortable with these things. But the truth is your doctor should be comfortable with these things because the chances that it will help, while maybe not very high, we don't know from studies, but the studies that are out there show that it might improve your ability to deliver vaginally. So for example, perineal massage that you might have heard of is something that Jenny again knows well. This is the example I use. If this is your vagina in the opening, you can use some kind of oil, for example, coconut oil, almond oil, olive oil, any oil that you would actually eat that is safe, you can put into your vagina and you would massage your perineum, the back part of the perineum, which is the area between your vagina and your rectum. So that back part of the opening, you can actually massage it to help it thin out and stretch out. And that potentially, when you're pushing, can lead to less likelihood of tearing. It doesn't mean you won't tear at all. And sometimes the perineum does tear, and that's okay because we need to give the baby space. But it can lead to less tearing from some studies. And as Jenny knows, so Jenny's going to comment on this in a sec, it really does help you kind of get in touch with your body a little more, or maybe help you and your partner get in touch with your body a little bit more. So you can try it on your own. Your partner can do it for you. This is something where, as much as I hate Dr. Google, I would say you can certainly Google perineal massage. The second thing before Jenny comments on perineal massage is eating dates. There was one study, not a robust study, but one study that dates, because of some enzymes, can help thin out your cervix, what's called effacement. And the study showed that if you started eating about 5 or 6 dates a day at 35 weeks, you might help thin out your cervix. So you could put them in a smoothie. You can eat the dates alone. I would avoid it if you have gestational diabetes because there is a lot of sugar in dates. And again, that is something where I would just talk to your doctor and see what they think. And at best, they're going to say, great, I've heard of it. And at worst, they're going to say, no harm, probably go ahead and try it. So I think it's worth, someone asked about red raspberry leaf tea or nettle tea. Yeah, there's data about that too. I don't tend to encourage that as much just because frankly, not everyone likes tea, although not everyone likes dates, but there's not as concrete data. But yes, red raspberry leaf tea and nettle tea are also two things that you can try that might precipitate labor. Dates specifically, it was effacement of your cervix, meaning thinning out of your cervix. We're going to talk about vacuums, forceps, and the third degree, but I want Jenny to talk quickly about her perineal massage because she really did think it helped.
I really do, but I think it helps for a different reason. There's two reasons: for the physical reason that Shiva has just described with the stretching of the skin. But interestingly, I tried to do it myself, and I find it's awkward because when you're kind of like in a crunch position trying to do something like that, you can't really relax your body. And so if you're comfortable getting your partner involved, I do think it's beneficial, because as I like to describe it, the first time, it's because it's not a sexual thing, and you feel very vulnerable and you feel a little uncomfortable because you don't feel sexy at all. But for me, it was like, all right, well, I'm going to have to start getting used to this position that I'm in. And so for the weeks leading up to the baby's birth, we did it a couple times a week, 2, maybe 3 times a week, just for 5 minutes. That's what they say to do. But it was really helpful for me to just get comfortable with my body. My husband was there. He was getting comfortable with it too, and just sort of being vulnerable in that position. But then when he's doing it and you can be relaxed, he or she, I'm sorry, whoever your partner is, when your partner, when you're able to lay down and really relax, I think it helps with the process. And then they can actually stretch the skin probably more than you might do to yourself. And I wanted him to do that. I wanted it to be, to feel a little of that burning, which is how they describe it should feel if you're stretching the skin. So those are my reasons to do it. And I found it to be helpful. We're going to get into the episiotomy because I actually did have to have one. So I guess, should we do that? Should we do that next?
I think let's go through this part, because I think this, and now I got to go like flash around, like quick, right? So Jenny, and using her example, so she got to the point where she was pushing for about 3 hours. I actually had one of my partners deliver her because I wanted to just pretend to be like the birth support person and be the photographer.
She was my doula, basically.
He was your doula. He gave me that look where he said, he thought, I think we should cut an episiotomy because her baby's head was crowning for a long time. And there's nothing dangerous about that exactly, except that babies don't like their head being compressed too much. So when I say crowning, meaning just that part of the head was sticking out. So 2 things: that puts a lot of pressure on the perineum, which means more chance of things like incontinence, meaning loss of urine in the future as we get older, which we want to avoid. Second is that part of the baby's head getting squeezed sometimes lead to some heart rate decelerations. And third is just the mechanics. After a certain point, you're exhausted. You've been pushing for 3 hours, and to push the head past that taut tissue of perineum is hard. And so he looked at me kind of like, what do you think? I think we should cut an episiotomy. And we are definitely of the mindset that we should discuss it with the patient. And I hate to say ask or tell, but discuss it. Sometimes there's not a lot of time. Sometimes if the baby's heart rate drops quickly and you need to get that baby out fast, I can't say I'm having a really like, hey, I think I want to do an episiotomy. What do you think? We don't have time for that discussion. But up until then, I've really discussed it with patients. So in that moment, I might say, listen, I really think to get the baby out safely, quickly, I need to cut an episiotomy. And to this date, I've never had someone say no, because they know, again, collaboratively, that my partners and I do not cut episiotomies unless necessary. The majority of doctors and nurses and midwives nowadays have under a 5% rate of episiotomies. So we don't cut it frequently, but the times we do are when we need to get a baby out quickly, or when we think that your perineum is too thick and you won't be able to push past it at the point that you could have already gotten the baby out, or if it's really taut and not elastic, and we think that you're going to tear upward near your urethra, then we sometimes make the decision to cut the episiotomy so that you don't tear upward. The purpose in not cutting the episiotomy is that it can tear further into a 3rd degree or 4th degree tear, which is the muscle around the rectum, or the actual rectum, meaning inside. I know that Leah has a comment here that in her first labor, she had a bad tear, which is a 3rd degree, which can be really painful and hard to recover from, though many people do recover, of course. Is it likely that she will tear that badly again? She's asked, and the good news is no, meaning once you've had a 3rd or 4th degree, you are more likely than someone who's never had one to tear, because again, that tissue is a little bit delicate. It might imply that your perineum, meaning the space between your vagina and your rectum, is shorter. So there can be certain mechanical reasons that it might recur, but it's not as though the likelihood is you will have one. So Leah, I'm glad that I can say the likelihood is you will not have a 3rd degree. You will likely still be able to deliver with no tear, a small 1st degree, or a 2nd. Second babies almost always come out faster and easier, just so everyone knows, even if they're bigger. So that's the good news. Someone asked about a vacuum. So let's talk about the pushing, right? And then we'll talk about the vacuum. So you push, if while you're pushing, your doctor or midwife or nurse, depending on who's examining you, determine that the baby's head is consistently making its way down, then they will continue to allow you to push. But at some point, if they say, listen, there has been no descent, there's been no movement in that baby's head, then it's sometimes safer to stop, and say, let's do a C-section now, because doing a C-section, even while you're pushing, is already more challenging. But as you can imagine, it's even harder if you've been pushing for 3-4 hours with no descent, meaning the head has not come down. Then getting the baby out through a C-section can be more challenging, because then the doctor has to pull the baby kind of up into your pelvis, out of where it's kind of deep in your vagina. Sometimes the doctor has decided that you have pushed enough, and either because you're exhausted or because they don't think you can necessarily push past a certain point, but they've made the assessment that a vacuum or forceps would be appropriate to get the baby out, and that would stop you from needing to have a C-section. But you can't always do forceps or a vacuum. First of all, you should talk to your doctor if you're curious about it, because many of us do not do forceps because we just weren't trained as much. Even though I've done this for 22 years, many of us just have never chosen to do it for various reasons. So our practice, for example, does vacuums when we need to, meaning the vacuum, which looks like a little round plastic cup that sits on the back of the baby's head and applies a small amount of force, meaning you still do most of the pushing, and then the doctor or midwife, usually it won't be a midwife, it would be a doctor who would assist a midwife, will put that little suction cup on, and they will gently pull while you're pushing. I kind of say to patients, I'm estimating that I'm putting about 5% force and you're still doing 95%, but that 5% can be very helpful. Again, either because you're exhausted or because you need that little extra oomph to get past the perineum, or because the baby's heart rate is dropped and you no longer have the latitude of kind of waiting another 15, 20, 30 minutes to push. Those are the reasons why the doctor might decide that she needs to do a vacuum. If she's going to do a vacuum or forceps, it is a little bit more likely that she might cut an episiotomy because she needs more space to be able to get that baby out. I don't want patients nowadays to have such despair when it comes to episiotomies. Like when I started 22 years ago, the routine was we cut, and then about 2 years into me being in practice, all the data came out saying stop doing it. I'm glad we don't do it routinely, but it's become one of those things, much like C-sections, that because everyone talks about, oh my gosh, how much we should try to avoid it, then when you need it, you are led into this fearful mindset of it must be terrible. The likelihood of an episiotomy turning into a 3rd or 4th degree is still not very high. The likelihood that you will recuperate and recover from a episiotomy is still pretty good. When I say recuperate, I think we all know, any of those of us who have had babies vaginally, that recuperation is hard, whether it's vaginal or C-section, especially after your first baby. You will potentially have a lot of swelling of your hands and your feet and your face and your perineum. So when I say you will recover, recovery takes different levels. We could have 3 more hours talking about just recovery alone, but you will ultimately recover. So I don't want any of you to be so against an episiotomy or so fearful of an episiotomy that if you have it, you think it's the worst thing in the world. It's not. It is a medical intervention that can be necessary.
And
Yeah.
I was just going to quickly add, because I know we in the effort to save time, I just want to say that, so Shiva came up to me and she said, listen, just like she said, I think you would really benefit from an episiotomy. And it hadn't even really occurred to me that I was more afraid of just like an uncontrolled tear than I was of a episiotomy. But I trusted the team so much that I was like, whatever you think is the right thing to do. And we did it. But this is what I'm going to say to every woman out there. If she had never told me that they were cutting one, I would not know to this day. And I'm being so serious, because you can't feel it. And when you are healing down there, everything is healing, and you can't distinguish between that little thing, I mean, what is it, Shiva?
Well, I mean, we try to only cut typically, let's say anywhere from like 1 to 3 centimeters at most. But again, even when we cut, it might tear a little bit, but not necessarily tear into the 3rd degree. You know?
Right. So to me, in my mind, I was like, they're in control. They're going to do this. I like the idea of it, even if that may not statistically be true. The idea of a controlled cut versus an uncontrolled tear, to me, I was comfortable with. But my bigger point is, honestly, in that healing process down there, everything is healing. And it's very hard to distinguish what's going on down there for weeks. Yeah. So I don't panic about it, because honestly, I would not have even known. I would not have known.
Well, and I love that point, because again, because it's gotten so much negative press, I think when someone hears they've had an episiotomy, they assume that their challenging healing is because of the episiotomy, when in fact, to Jenny's point, the challenging healing can be pushing a human out of your vagina, especially if you've pushed for 2 or 3 hours, is hard. It doesn't mean you won't heal, but you will potentially be very swollen just from the head pushing. And so whether or not it's a tear or a cut doesn't necessarily make the healing harder or easier. I always say, like, I never want to be scary and be like, oh my God, it's terrible, it's the worst. But I also don't want to sugarcoat it. And I think it's valuable to know that healing is challenging, but typically the first day or two are the worst, and then you feel exponentially better in the course of the first week after. Some of us, like in my case, I actually did have trouble sitting for long periods of time because my tailbone was fractured a little bit from my baby's head being sunny side up and the back of his head kind of pushing on my sacrum for that 3 hours. But I was back at work. I was okay. I was doing well. I just felt different. Your body has to heal. So again, do not be fearful of the episiotomy. Your doctor will sew everything up appropriately. I really want us to take a couple of minutes to talk about pooping. You will likely poop. I just need everyone to understand that. Patients say to us all the time, like, but what if I poop? And I'm like, I expect you to poop. In fact, if you poop, that means you are pushing the right way. Don't worry about pooping. I don't ever want patients to even ask unless they really want to, because I don't want to have to say to them, oh yeah, you pooped, because I think it makes them worried and uncomfortable, but I don't care about pooping. None of your nurses care about pooping. We often joke, we don't want to do anyone's pedicure, but pooping does not bother us. We are used to poop, amniotic fluid, blood, urine. These are the things that make up our world. So please, 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 if you're going to spend any time worrying about anything, do not worry about pooping. To that point, I will tell you that the more empty you enter the hospital, meaning the more empty your bowels are before an induction or labor, and certainly a C-section, the easier it will be for you to heal. I made the mistake of eating like a massive spaghetti carbonara dinner before I got induced, because you don't eat once you're at the hospital, right? This is what we tell you. Go ahead, eat. And even as the doctor, I ate a huge meal. And then after my labor and my induction, I was so constipated that it was really hard to poop. So I actually try to encourage my patients not to starve, but to have lots of thick liquids like soups and smoothies and shakes. And really in the days leading up to that end of labor, of the end of pregnancy, if you're not pooping regularly, magnesium can help you poop. Stool softeners like Colace and Senecot, Miralax, whatever you can to help you poop, because in fact, it also might help stimulate labor, because when your bowels contract, that can help stimulate labor. So I would advise you to do anything you can to try to get yourself to poop, not because your doctor or nurse care if you're pooping, but because you'll feel better postpartum. Someone asked about an enema, and that's actually a great question. So in some countries, they still use an enema to help precipitate labor. So if you feel up to it, you can certainly, either you or your partner can help you do an enema. I wouldn't say that I encourage people, for example, to use laxatives because you don't want to get dehydrated. But if you're really constipated, then using a laxative for a day or two just to really get you to poop. And again, not only does it help empty your bowels so that you don't have to be uncomfortable, but when your bowels contract, like I said, that can stimulate labor if your body's getting ready to go into labor by a day or two. Similarly, semen. So if you have access to semen, as we joke, semen has prostaglandin, and that can help precipitate labor. And this is why we also talk about, people will say things like spicy food. Spicy food does not do it. It's if spicy food causes you to have a bowel movement. So bowel movements, semen, and when your doctor or nurse midwife examine you, they can strip the membranes, meaning they can examine your cervix, stretch out the cervix a little bit by separating the membranes from where they're attached in your uterus. And that can also help precipitate labor if your body is getting ready to go into labor. Okay, if anyone has last minute questions, put them in. I wanted to do a couple more kind of mindset things, because some of your questions had to do with fear and emotion. How can I prepare now to move out of my current fear mindset, was one person's question. And another person's question to piggyback on that was, are extreme emotions like crying and yelling during labor a waste of energy? How do we stay calm? Breathing, hypnobirth, mantras. I think that if you can do a hypnobirthing class with the idea being, I'm going to do a hypnobirthing class to help keep me calmer until I get an epidural, until I need a C-section, until I deliver vaginally, while my baby is crying. Like, these are all, I think hypnobirthing can be a great tool to help you in general, because hypnosis can be powerful. I think using hypnobirthing and assuming that it will lead to an easy labor is probably going to misguide you. I think the biggest way to decrease fear is to remember the likelihood of something really bad that is irreversible is incredibly small. So I say to patients all the time, nerves are normal. I will never say don't be nervous and anxious, but don't be scared. Fear, as Jenny hears me say all the time, is something we should reserve for when we're being chased by an animal in the wild. Short of that really nerve-wracking, fearful event, don't use fear at the hospital. Don't invoke fear. Don't even use the word fear, because if we believe in manifesting, we want to put that aside. So I say to patients, it's okay. You can be nervous. I'm not going to tell you not to be nervous. You're about to be a mother. This is amazing and miraculous and nerve-wracking, because you don't know what's going to happen. And I can't guarantee everything's going to go smoothly, but I can guarantee that if we collaborate and work together, we will have a good outcome. That good outcome might be easy. It might be really hard. It might be nerve-wracking. It might be easy, but we can have a good outcome. And that was the beauty. I mean, I've had the most beautiful labors and deliveries that were the most challenging, but in the end, they ended up being amazing because the patient and I both felt validated and heard. I've similarly had other ones that were super easy and nothing special because the patient didn't feel particularly involved in the situation, nor did she validate me. And probably she didn't feel like I validated her. So it's really important to find a practitioner that you collaborate with and try to remind yourself the likelihood of anything calamitous is very small. Doesn't mean that there won't be emergencies. There might be emergencies. I have to be honest about that. I deal with them every day. That's why I have so much stress, but we can deal with those things well, especially when we have good relationships with our patients, right? So
And
speed
you
it
know,
up. Penny, what do you have to do?
well, one thing I was going to say is for me, like when I had the baby, that was basically the first time I'd ever been in the hospital, which I realized that I'm very fortunate to be able to say that. But I think the reason I bring it up is because there was so much like, I mean, what I know in the hospital is Grey's Anatomy, you know, like I didn't know, or what you see in the movies. And to that person's point about the question of the screaming and the yelling, in our pregnancy program, we filmed my entire labor and birth, and we show the girls my pushing, and the number one comment. So for anyone, if you're early enough in your pregnancy and you'd like to join our program, you will get to see that. But the number one comment that we get after they watch my labor video is, oh my God, like it's so different than what they show in the movies. You know, I mean, it's not easy to push, but it's not this like dropping the F-bomb and sweating and like, I mean, I'm sure that exists. I'm sure it exists.
Sometimes,
but
yeah.
But I would say typically, you know, pushing is a, you know, it's a hard thing, but it's not what they show in the movies, you know. So
Fast and Furious with your first. And yes, Stephanie, I apologize. We didn't talk about it. So let's go through this part really quickly. I feel like we always go over an hour. I just want to be respectful of your time as people on our panel here. So the baby, let's say the baby comes out, the head comes out. Your doctor then very swiftly checks for a umbilical cord wrapped around the neck, because sometimes your doctor will have to reduce that cord. Other times she'll be able to let your partner cut the cord afterwards. The baby's head comes out, the shoulders come out. The doctor sometimes has to do some maneuvers to get the shoulder out safely and so that the baby can actually be okay. And sometimes the shoulder gets stuck. So you might notice the doctor spring into place with the nurses, do all kinds of maneuvers, get the baby out. Then, assuming the baby is showing a sign that the baby's okay, meaning either crying or good tone and good color, we'll leave the baby attached for 45 seconds at least, where it's delayed cord clamping. And then we'll let you or your partner or one of the doctors or nurses cut the umbilical cord. And then if the baby's fine, they'll keep the baby on your chest to do skin to skin. And during that time, this is where we're going to get to Stephanie's question. During that time, your doctor is now assessing your perineum to see about the tears or lacerations, and we're waiting for the placenta. The placenta can take up to 30 minutes before it comes out. Ideally, it comes out sooner, but immediately after the placenta comes out, you can imagine your uterus is big, it has a baby. Then it shrinks and it has just the placenta. Then the placenta comes out and the blood supply to the placenta is still there in the uterus. So the uterus needs to contract in order to clamp down the blood supply so that you don't bleed too much. You will automatically, in most places, get IV Pitocin, whether or not you've needed it in labor, to help that uterus contract. But one of the parts that helps your doctor make your uterus contract is, once the placenta comes out, massaging the top of your uterus called the fundus, and sometimes having her hand in your uterus through your vagina to massage it that way. And that isn't always necessary, but it serves twofold. It helps the uterus contract, and it's really sometimes necessary if your uterus is too flaccid where it bleeds too much. But the second part is, even once the placenta comes out and we inspect it to make sure it's come out in its entirety and we haven't left anything in, there can be little fragments of membrane, and you don't want to leave that in. So if someone's comfortable with an epidural, we do tend to do this bimanual massage, or fundal massage, we call it, where we rub on the uterus. Even if we don't do it right after the placentas come out, your nurse several times throughout your postpartum, like in the immediate couple hours, and then when you're on the maternity ward, will have to kind of touch and massage your uterus sometimes, because if not, your uterus can relax, clots can form, and that can cause too much bleeding. So unfortunately, Steph, I don't want to say that you can avoid it, because likely you'll need it, but you can talk to your nurses and doctors about how much do you need it and what else can be done. But it serves a purpose. Yes.
And real quickly, to add to that, one more thing, because this comes up a lot. If you've had an epidural, okay, I'm just going to go in as the person who had the epidural. You're not feeling anything down there anyway. And more importantly, though, after that baby comes out, if everything is normal and the baby's on your chest, You are so unaware. I have no memory of the placenta coming out. I have no memory of being sewn up. I can see it. I saw it in the video. Zero memory of any of it because your brain is so in one place. And so don't worry so much about that because I literally have zero memory. I could only tell you it happened because I saw it in the video later.
Yeah.
So just don't spend a lot of time fearing those like after birth things so much.
Yeah. And so, but that's a good point. And so after the baby comes out and they try to massage your uterus, let's assume the placenta comes out and there's no bleeding. Great. If the placenta comes out and there is bleeding, your doctors and nurses have a series of things that they can use. There's 4 to 5 medications we can use to stop the bleeding. And I can't say that happens infrequently. So there are definitely times where the patient is snuggling with the baby and I'm like, you're having a bleeding. I'm going to take care of it. I'm going to tell you we're doing X, Y, Z. I want to keep them involved without making them be too anxious about the situation. The last thing I want to say is this. We've kind of talked about like, what is the ideal? The baby comes out, you get to do skin to skin, delayed cord clamping. The truth is sometimes the baby comes out and the baby is either a little bit flaccid, a little bit blue, not crying. Maybe the cord was around the neck a little bit tight. Maybe there was no cord around the neck, but the shoulder got stuck. So there might be different reasons why the pediatrician has to be in the room or has to be called in to help attend to the baby. And then you don't get that immediate skin to skin and you don't get that immediate bonding. Maybe even the baby has to go to the well baby nursery or the NICU. And while that's frustrating and that's nerve wracking, and that's not ideal because we have our plan of what we'd like, we all have to remember that as long as in the end you and that baby are happy and healthy, that is what we care about. So I really want my parting words and Jenny's like feelings to be, in the end, you and the baby will be okay. Please try, as much as all these ideals exist. And on the internet, it gets a big push to really make women feel shamed about not delivering vaginally, not nursing, all those things. But try to remind yourself, this is a process that can have a lot of different ways that we're going to get to a good end outcome. And the end outcome is not vaginal or C-section, epidural or not, breastfeeding or not. The end outcome is you and the baby are being happy and healthy. And so much of that has to do with your mindset more than the actual route that you got there. Okay. Jenny, anything else that you want to add?
No, not on that, but someone did ask about cord banking. Do you want to just do your 2 seconds on that?
Last thing, cord blood banking. So cord blood banking, which if you don't know, is where you can pay a few companies. There's many companies throughout the country. I can't say which one is the best because it's very like regional dependent, which ones market the best. And you pay them a lot and they send a kit so that your doctor can collect the cord blood at the time of the delivery from the placenta. And that cord blood can then be used to save stem cells, which are the cells that they may be able to use in the future if God forbid you need it for leukemia, lymphoma, potentially other issues, either with your own child or with siblings. It sounds great and stem cell transplants are amazing, but frozen cord blood stem cells have not been really proven to work. So we really don't know if it's going to work. So my feeling has always been, if it were proven to work or if it were cheaper, it used to be about $1,500 to $2,000. Some of the companies have come down in cost, but if it were proven to work or cheaper, I would support it. Because it's not proven to work and it's not really cheaper, I'm not against it, but I would never encourage my patients to spend that much on something we just don't know. And that's really in keeping with also the American Academy of Pediatrics and American College of OBGYN, who really speak out against the private banks because they really do encourage people to spend a lot of money without actually having great data to prove that it can work. So we could go on for hours, but we won't. But if you like what we've talked about, come on over, come follow us at Tribe Called V or on our Instagrams. We have our own independent Instagrams. And our program, I have to say, not to tout ourselves, but it's really fun. We have an ebook that people can buy separately. That's, I think, $19, where we wrote all the things that we could think of to decrease anxiety with regard to anything in pregnancy, not just labor. And then our program is great. It's 2 Zooms a month that are live, but you can watch all of them taped. Some of the people in our program never show up live and they just watch all the taped ones. We sometimes have specialists, like we had a pelvic floor PT on last night. We have infant feeding people, CPR, and we have fun because the truth is, I always say, even the chattiest of doctors like me cannot cover everything during our exams in the office. And while I wouldn't say you need all this information, it really is nice to have it, because if we don't give it to you, then you turn to Dr. Google and you get the crap scared out of you, and we don't want that. So,
and the other thing I'm going to just throw out there, now that I've been in this baby thing for a little while, you know, this post-COVID world, you know, the mommy and me groups, the group gatherings just they don't exist right now. And so one of the things that we've discovered through our pregnancy program, and now we've developed our postpartum program, which has been so amazing, is the community that is established through these groups, because it's not just about education and information. It's truly getting to know other women that are going through the same thing and feeling support, because I mean, there literally are no mommy and me groups. It's you cannot find them. So for the postpartum thing, I think it's particularly helpful. So check it out, because the community portion, I mean, after you have that baby, you are going to want to talk to other women that are going through the same thing. It is just a fact. So I love what we're doing, and I'm really excited.
So Lucy asked about Instagram. Mine is Big Love Fierce Juju. Jenny, I wrote Saltwater Wellness, but there's a underscore in there.
Yeah, here, I'll type it in.
And our Instagram is, our together Instagram is Tribe Called V. I'm in my attic studio, and our website is tribecalledv.com. So there's all the information there. And if you ever have questions, you can always reach out to me or Jenny on her Instagram, my Instagram, or our Tribe Called V, and ask us questions. Okay. So thank you all. I hope that was helpful. Let us know if you need anything else. And honestly, like, our ask is just be calm, be faithful in your providers. And if you don't like them, then switch. Don't, stick with them and try to make them bend towards you. And really, 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 if you like what we talked about, then come join us and spread the word. Okay. All right.
Yeah.
Thank you.
Ladies, you've got this, especially for I saw a few dates. You've got a few of you that are going any day now. So yeah, you got this.
You got it. All right. Okay. All right, everybody. Happy holidays. Bye.
Happy holidays.
Oh, wait, I'm going to do one quick screenshot, Jenny. All right. Hello. Okay. All right. Thanks, everybody. Have a good night. Bye.
Bye.